Good day, doctors. Today we will discuss complex dental disease prevention programs and situational analysis as basis for planning prevention programs. Lecturer Makusheva Natalia Vячеславовна, Department of Pediatric Dentistry and Orthodontics. Goal of lecture: know the principles of planning a complex prevention program. Lecture questions. Principles for planning a comprehensive prevention program. Analysis of the situation. Contingent, method and tools, organization activities, evaluation of the effectiveness of the program. Relevance. Prevention of dental diseases of the population is a national task. Practical realization of mass prevention of dental diseases is possible only through specific programs developed by each region. In accordance with the intended preventional goal, real material and technical base and staffing. According to job responsibilities, each dentist must carry out primary prevention in the form of planned activities using the allotted time budget. An additional key to solving the program is also the use of kindergarten educators, teachers, pediatricians for the practical implementation of primary prevention of dental diseases. Main stages of the developing and realizing of programs of mass prevention of dental diseases. The first stage is determination of dental problems among the population of the districts, for example, city, region, etc. Second stage is setting the general goal and objective of the program. Third stage, choice of methods and means of prevention. Fourth stage, staffing. Fifth stage, material support. Sixth stage, information support. Seventh stage, evaluation of the effectiveness of the program. Determination of dental problem, the first stage. The World Health Organization recommends the introduction of problem-oriented programs aimed at solving current or projected problems. Therefore, the first step in developing planning a program is to identify problems. It is very important not only to detect dental diseases, for example, dental caries, but also to study their prevalence and intensity as well as access based on the experience. The real possibilities of disease prevention, for example, are they available, are they effective, etc. Means and method of caries prevention. As a result of identifying problems and analyzing the situation in the future, it is possible to formulate measurable goals and objectives of the program, and therefore objectively assess the effectiveness of the program. It should be borne in mind that if the first stage of planning is ignored, then control and evaluation of the program is impossible. In different areas, the intensity of dental caries varies from low to very high, according to the World Health Organization classification. It is especially important to carefully orient the prevention program to local conditions. Currently, the most common dental diseases are dental caries of moderate intensity, on average 3.4 dmFT of teeth of 12 years old children, and periodontal diseases 100% of adolescents and adults. A striking example of the work of the prevention program was the decrease in the incidence of dental caries in cities with the use of centralized fluoridation of drinking water. As a consequence of defining the problem, identifying the factor, the application of a preventive measure aimed at the factor. In a number of cities, the fluoridation of drinking water was introduced, for example, St. Petersburg, Moscow, etc. There has been a tendency of a decrease in the intensity of caries. At the same time, in other cities, as well as in rural areas, especially in the regions of Siberia, the Far East, caries is growing. The second step of the planning of the preventive program is setting the goal and objectives of the program. The goals and objectives of a prevention program must be measurable. Otherwise, it is impossible to assess and predict its effectiveness. To determine the hygienic status of groups of different ages, the oral hygiene indicates that you passed last year are used. For repetition, I will tell you briefly again about these indexes. Kuzmina, Fedorov-Volodkiny, OHIS, and PHP. Detection of plaque with help of indexes. The first index is Kuzmina, index for evaluating plaque in young children. To access the amount of plaque in a small child, from teething of temporary teeth to 3 years, the teeth present in the oral cavity are examined. Evaluation is carried out visually or using a dental probe. The amount of plaque must be determined even if only 2-3 teeth are present in the child's oral cavity. Code and evaluation criteria: 0. No plaque detected. 1. Plaque covers part of the surface. So, if the child has 3 teeth and 2 of them with plaque, first 0, second 1, third 1. We summarize of teeth with plaque and divide it on sum of teeth in the oral cavity. So in our case, we divided 2 on 3. Summarize the teeth with plaque and divide by number of teeth in the oral cavity. And then we interpret index. 0. Good oral hygiene level. Enough oral hygiene and bad. If you have 0.1 to 0.4, it's enough oral hygiene, and 0.5 to 1, it's bad oral hygiene. It's Kuzmina index for child, small child, with temporary bite. Next index is index according by Fedorov-Volodkiny. We use this index for evaluating oral hygiene in children by 5 to 6 years old. Using the index, you can evaluate the amount of plaque by examining the surface of the teeth. Plaque is detected using dyes: Schiller-Pisser solution, aqueous solution of iodine, plaque stain tables, erythrozine, fuchsin, etc. We examine 6 teeth. On the low jaw is the frontal teeth: 7.3, 7.2, 7.1, 8.1, 8.2, 8.3. Canines and incisors on the low jaw. And then when we examine the teeth, we see the plaque on the teeth, or we doesn't see plaque on the teeth. If no plaque, we put on code 1. If we see a quarter of teeth with plaque, we put on code 2. If a half of teeth have a plaque, this will be code 3. If the plaque cover 3/4, we put on code 4. And if plaque covers more than 3/4, we put on code 5. Then we summarize chord of the teeth and divide it on 6. 6, this is sum of all examined teeth. And then interpret index. Oral hygiene in this index can be good, enough, not enough, bad, and very bad. Next index is OHIS by Green Vermilion, Simplified Oral Hygiene Index. This index using for children more than 7 years old and the adult. Using the index, you can separately evaluate the amount of tartar and or plaque by examining the surface of the tooth. We examine 3 teeth on the upper jaw and 3 teeth on the lower jaw. In summarize, 6 teeth. 1.6, 1.1, 2.6 and 3.1 we examined on the vestibular surface, and 3.6, 4.6 lingual surface. We dyeing these teeth and examined it. If the teeth no plaque and no tartar, we put on code 0. If the surface has 1/3 with plaque or tartar, we put on code 1. If the surface have from 1/3 to 2/3 surface of plaque or tartar, we put on code 2. And if the plaque or tartar covers more than 2/3 of the tooth, we put on code 3. Plaque and tartar determined by using days or a dental probe. Formula. We summarize the codes of plaque and divide it on 6. Then we summarize it with sums of code of tartar divided on 6. So we have a index and we have to interpret it. Interpretation. The hygiene level can be good, enough, and bad. We can count separately only tartar or only plaque. This is the first case of interpretation on the slide. But we can count tartar and plaque together. This is second case of interpretation on the slide. The next index is Oral Hygiene Effectiveness Index, PHP. Plaque is determined using days, like the other index too. Schiller-Pissarrev, tablets, erythrozine, fuchsin, etc. The same teeth as in Green Vermilion or his index are examined. 1.6, 1.1, 2.6, 3.1 on vestibular surface and 3.6, 4.6 lingual surface. If there is no tooth, examine the neighboring of within the same group. Fixed crowns and parts of polishes are examined just like a tooth. The tooth surface is divided into 5 parts: medial, distal, mid-occlusal, central, and mid-cervical. We divided surface of the examined tooth. and put on codes. 0, no plaque detected on the tooth surface. 1, plaque converse part of the surface. So, if the tooth 1.1 has the plaque on the cervical surface, we put on code 3 because plaque is on the medial surface, on the mid-occlusal, and on the distal surface. Mid-cervical, mid-cervical. 3 code. Then we summarize all codes of all parts of tooth. So, for example, the tooth 1.6 has code 3. 1.1 has code 2. 2.6 has no code, etc. We summarize these codes and divide it on 6. And then interpret index. Oral hygiene index PHP has 4 interpretation. Hygiene level can be excellent, good, enough, and not enough. Measurements can have different parameters and relate to different aspects of the content of the program or its results. The World Health Organization recommends objective measurement criteria based on assessing the level of health using the DMFT index, where D decayed teeth, M missing teeth, about caries, and filled teeth. Depth index, where D decayed primary teeth, E extracted tooth indicated for extraction due to caries, F filled teeth, and the World Health Organization periodontal index CPITN and CPI by Leos. World Health Organization has proposed a global for the whole world index of dental health by 2000. The average DMFT index of teeth is not more than 3 at the age of 12 years, but unfortunately it is already 2020 and this index has not yet been fulfilled. Let's remember 2 periodontal indexes. The first one is Complex Periodontal Index CPI by Leos by 1988. Method of this index. The condition of the periodontal tissue is determined using a conventional dental probe and a dental mirror. Dental tweezers can be used to determine ability. In adults, the teeth 1.7, 1.6, 1.1, 2.6, 2.7, 3.7, 3.6, 3.1, 4.6, 4.7 are examined. In the presence of several signs, a more severe condition is recorded. High score, the highest criteria. And criteria: 0. Healthy. Plaque and signs of periodontal damage are not detected. 1. Plaque, any amount of plaque. 2. Bleeding. Bleeding visible with the naked eye with light probing of the periodontal groove. 3. Calculus. Any amount of calculus in the subgingival region of the tooth. 4. Pathological pocket. Pathological tooth gingival pocket determined by the probe. 5. Tooth mobility. Mobility 2-3 degrees. An individual's CPI is calculated using the formula. CPI is sum of chords divided of number of sextants. Usually it's 6. And interpretation. Values intensity level. Risk of diseases, light, white, medium, and severe. And the next periodontal index is CPITN. This is the World Health Organization periodontal index. In this index, examine the following teeth from all sides. In adults, the index is assessed in all 10 teeth. In children, the condition is recorded in only 6 of them. 1.7 or 1.6 for children and both for adult. 1.1. 2.6 or 2.7 for children and both for adult. 4.7 or 4.6 for children and both for adult. 3.1 and 3.6 or 3.7 for children and both for adult. Next surfaces are examined. Mesiobuccal, buccal, distobuccal, mesiolingual, lingual, and distolingual. 6 points as a result. For examination, use calibrated periodontal probe. Scoring criteria. Healthy, bleeding is observed, calculus is detected, pocket less 5 mm is detected, and pocket more than 6 mm is detected. Index CPITN will be the sum of the points of the examined teeth divided to 6. And interpretation. Each sextant evaluated on worst score of the index teeth, the highest score. For each sextant, there is no need for treatment. There is need for improving the personal hygiene. There is need for professional hygiene with scaling and root planning. And there is need for complex treatment. When defining measurable targets for the prevention of major dental diseases, the World Health Organization global criterion for dental health must be kept in mind. Based on the situation when, on a national scale, the average DMFT index of teeth of 12 years old children roughly corresponds to the global criterion for dental health. The program can be aimed at maintaining the current level or reducing it. Based on the analysis of the situation, it seems reasonable to propose on a national scale the following measurable objectives for the prevention of major dental diseases. The overall goal of a comprehensive dental program may be to reduce the intensity of dental caries, periodontal diseases, and their complications among the population. To achieve a common goal, it is necessary to define specific measurable objectives. Specific measurable objective of the program can be: the first, reduce the prevalence of dental caries in children 6 years of age to no more than 60%. Prevalence of dental caries in 6 years old children now around 80%. The second specific measurable objective of the program can be: reduce the intensity of dental caries in 12 years old to no more than 2.7 DMFT teeth per child on average. The intensity of dental caries in 12 years old children now is about 3.4 DMFT teeth. The third specific measurable objective of the program can be: to reduce the intensity of periodontal diseases in 15 years old children by at least 50% of the initial level. In children 15 years of age, the average CPITN is about 4.5. The average DMFT is 2.4. Now, the fourth specific measurable objective of the program can be: to reduce the number of extracted teeth in the population aged 18 years to more than 0.2 on average per person. The average number of extracted teeth per one, a person age 18 about 0.7 now. The fifth specific measurable objective for the program can be: to prevent a further increase in the number of extracted teeth in the population aged 35 to 44 years old. The average number of extracted teeth per person at the age of 35 to 44 years old is about 4.3. Specific measurable objective of the program number 6 can be: provide a good index level of dental care is at least 80% level of dental care for the entry child population of the country. Average level dental care index for children is about 45%, fluctuation from 6 to 86% in different areas. Districts. Level of dental care index. Knowing the components D, M, F in the structure of the intensity of dental caries, it is possible to determine what part of the population's problem associated with caries is solved, for example by sanitation or prosthetics. On the other hand, the quality of dental care can also be measured. The dental care level, DCL, is calculated using the formula. DCL is 100% minus multiplier 100 to sum of D and M divided on DMFT, where DMFT is the average intensity of dental caries of the survived population group, D the average number of untreated caries lesions, including caries in the filled tooth, and M the average number of extracted teeth when the defects of the dentition are not restored with prosthesis. DSL is calculated in percent. Depending on its value, 4 levels of dental care are determined according to the following scheme. Interpretation: bad, insufficient, satisfactory, and good. The specific objective of the program, which we describe in the lecture, can be a guideline for the development of measurable objectives in each republic, territories, regions, and districts. This is depending on the specific situation. Methods and means of prevention. For mass primary prevention of dental caries and periodontal disease, World Health Organization recommends the following methods: fluoridation of drinking water, the appointment of fluoride preparations inside, local treatment of teeth with fluoride preparation, sanitary educational work including advice on nutrition, regular oral hygiene from childhood. It seems appropriate and reasonable to recommend all the above methods of primary prevention and secondary prevention for implementation. However, only health education, oral hygiene, and secondary prevention are universal through the area. The choice of these methods should be differentiated in each region, district, etc., depending on the level of morbidity, concentration of fluoride in the environment, as well as dietary habits. The next stage is staffing. The implementation of the prevention program involves dentists or hygienists, nursing staff, teachers, parents. Dentists. Dentists manage the program and, if necessary, train nurses and other personnel. The need for dentists for a prevention program is a half or a quarter of the rate for the administrative region where the program is planned to be introduced. Hygienists. Hygienists conduct complex preventive procedures including training and professional cleaning of teeth for from 2 to 3,000 children per year. Hygienists organize training of personnel in the method of conducting hygiene products, controls the quality of teeth cleaning, performs special prophylactic procedures such as applying fluoride varnish to teeth, rinsing the mouth with fluoride solution, etc. In this method, hygienist treats from 3 to 4,000 children per year. Dental office nurses. Dental office nurses. Distribution of fluoride tables. Rinsing the mouth. Training and control of teeth cleaning. sanitary and educational work. Kindergarten teachers and school teachers. Kindergarten teachers can be used to teach oral hygiene. School teachers and kindergarten teachers can control of teeth cleaning, sanitary and educational work. Parents. Parents can conduct training and control of teeth cleaning, education of healthy habits. Material base. Material base. To implement a prevention program, you need sanitary educational materials, medicines, oral hygiene products. In the process of developing the program, the exact amount of these materials is calculated to fully cover the contingent of the population included in the program. It should be borne in mind that the prevention programs is long-term. Therefore, calculation of materials are carried out for the entry period of the planning program, for the next 5 years, and for the first 2 years of program implementation. Information support. It seems appropriate to introduce a centralized computer information system on the dental status of the population to assess the effectiveness of the prevention program. At the first stage of implementation, it is recommended to develop and approve evaluation criteria, index, terminologies acceptable throughout the country and comparable to the international one. Dental examinations of the population should be carried out according to a unified methodology by a well-trained epidemiological team at least once every 5 years. Efficiency evaluations. Evaluations of program effectiveness should be developed during the planning phase. To this end, the objectives of a dental prevention program must be measurable, provided objective criteria are used. These criteria are used to evaluate the end results of the program. However, you can also plan evaluation of the program progress or of its individual components. In dentistry, the evaluation criteria for a prevention program are data on the dental status of the population, the intensity of caries according to DMFT or DEFT indexes. The intensity of periodontal diseases indicates CPI and CPITN. The indicator prevalence of these diseases is less informative, especially when researching the population in areas with high disease intensity. Remember that the intensity of caries in an individual is determined by the DMFT index and DEFT. The intensity of caries in the group is determined by the sums of the indexes in the group divided by the number of people in the group. The prevalence of disease in the group is calculated as follows. The number of people who have a disease in the group is divided by the number of people in the group and multiplied by 100%. The KH groups for assessing prevention outcomes are children aged 12 and 15 years. Sample studies are conducted on from 20 to 50 children in each of the study areas. It is recommended that this work be entrusted to a dedicated group of trained epidemiologists-dentists. Example of a complex prevention program. As an example of a complex program for the prevention of the dental diseases, we will consider complex program for prevention of dental caries and diseases of periodontal disease in children. The first section of complex program for prevention of dental caries and periodontal diseases is analysis of the situation of the district or city. And the first step is demographic data. In this program, we take child population under 14 years old and preschool children. organized preschool children. The group. The second step of first section analysis of the situation of the district or city is environment factors. For example, centralized water supply and concentration of fluorine in drinking water. And the third step of section 1, analysis of the situation of the district, is risk factors for dental diseases, summarized for different age groups of children, adolescents, pregnant women. The fourth step of the section 1, analysis of the situation of the district, is dental diseases. The most common dental diseases in children, dental caries and periodontal diseases. The intensity of these dental diseases. The key age groups for assessing prevention outcomes are children aged 12 and 15 years. Section 2. Program Objectives. The overall goal of the prevention program is to improve the health of children by significantly reducing the intensity of dental caries and periodontal diseases and reducing the number of their complications. The measurable objectives of the program are reducing the intensity of dental caries in children by 12 years old of age is no more than 3. A decrease in the intensity of periodontal diseases or an increase in the average number of healthy periodontal sextant in adolescent 15 years old of age at least 3 times. Section 3 of Complex Program for Prevention of Dental Caries and Periodontal Diseases in Children is contingent. The prevention program covers all children of the district from birth to 14 years old, as well as all pregnant women, for antenatal prevention of dental diseases in children. Section 4 of Complex Program for Prevention of Dental Caries and Periodontal Diseases in Children is Prevention Methods. The program includes the following methods for the prevention of dental caries and periodontal disease. The first one, the health education of healthy lifestyle for the prevention of dental diseases. The World Health Organization defines healthy living as a healthy lifestyle is a person's behavior and thinking which provide him with the protection and straightening of health, an individual system of habits that provides a person with the necessary level of life activity for solving tasks related to the performance of duties and for solving personal problems and requires a life system that ensures a sufficient and optimal exchange of a person with the environment and thereby allows maintaining health at a safe level. The way of life is formed by the society of the group in which the person lives. Therefore, the formation of a healthy lifestyle is not a medical task, but primarily an education one. The way of life is realized in 4 areas: labor, public, family, and household. Leisure. All components of a lifestyle are integrated with each other by the following elements: interpersonal relationship, moral relation in society, acting as a regulator of human behavior. 2. Correction of children nutrition in relation of the frequency and amount of sugar intake. Healthy eating provides protection against malnutrition in all its forms, as well as non-communicable diseases, including diabetes, heart diseases, stroke, and cancer. Unhealthy diet and physical inactivity are major health risks around the world. Healthy eating habits are shaped early in life. Breastfeeding promotes healthy growth and improves cognitive development and can have long-term health benefits such as reducing the likelihood of gaining overweight, of obesity, and developing non-communicable diseases later in life. Energy intake should be balanced with energy expenditure, reducing free sugars to less than 10% of total energy intake. Salt intake of less than 5 grams per day. And for infants and young children, for the first 6 months of life, babies should be exclusively breastfed. One of the important prevention methods is teaching children effective oral hygiene. A huge number of different microorganisms live in the human oral cavity. They are deposited on the teeth, gums, tongue, and cheek mucosa. Colonies of microbes and their waste products lead to a variety of dental problems. In addition, getting into the body, bacteria provoke the development of pathology of the gastrointestinal tract. Therefore, Timely training in proper oral hygiene prevents the development of diseases of the teeth and oral organ. The next step is local treatment of teeth with anti-caries drugs. These methods are applied differently depending on the contingent. Section 5. Organization. The general management of the program is carried out by the district or city health department. The next department, which participates in organization, is District Department of Public Education. Its functions include ensuring the implementation of the prevention program in schools and preschool institutions, determination of the responsibilities of the personnel of the education system for the implementation of the upbringing of a healthy lifestyle of children, publishing instruction and orders for the implementation of the program in school and preschool institutions, monitoring the implementation of the program in schools, preschools, institutions. Next organization is Sanitary Epidemiological Station. Its functions include control and assistance in providing rational nutrition, rationing, sugar, salt, etc. in organized children's groups, control and assistance in ensuring the correct maintenance of oral hygiene products and mass prevention of dental caries in organized children groups. The next department is Women's Consultations. Its functions include health education of pregnant women on prevention of dental diseases in children, interaction with dental clinics for the issue of 100% coverage and complete dental care pregnant women. Next organization is Children Polyclinics. Its functions include health education for parents and workers of organized children's institutions of the prevention of dental diseases, coordination and practical assistance to the dental service in implementation of a prevention program in preschool institutions and schools. Nutritional control for sugary foods in preschool and school childcare facilitates. organization of the dentist's work in the room of a healthy child, monitoring and facilitating annual visits to unorganized children of the prevention cabinet. Next department is preschool institutions. Its function includes interaction with pediatric and dental services on the introduction of prevention, practical provision of daily brushing of children's teeth, health education for parents and prevention dental diseases in children, ensuring the recommended norms of rational nutrition for children. Schools. Its function includes conducting planned health lessons, including questions prevention of dental diseases, providing conditions for medical personnel treatment and preventive measures for children and adolescents in accordance with prevention program. Section 6. Staff. The program of mass prevention of dental caries and periodontal diseases in children of the districts is carried out by the personnel of the healthcare and education system existing in the district. Some preventive measures are carried out independently and by parents. Thus, the development and implementation of prevention programs are necessary for the improvement of population groups, depending on age and environment, with the use of specific and general methods of prevention. Thank you for the attention. This video you can see as usual.